palliative care is the type of care that we receive when we're palliative. And there are 5 phases in palliative care. The first phase is stable, which means, so let's say that I'm palliative, I have an illness or a disease that's going to cause the end of my life. So here are the 5 phases. The first one is stable. So stable meaning that I have all of my needs, my comfort needs, psychologically, emotionally, physically, spiritually, are all being met. I'm still dying from the disease. It doesn't mean that there is a cure or that I'm going to recover. It just means that I'm stable, basically comfortable. The second phase in palliative care is unstable, which is obviously the opposite of stable. And what unstable means is that something's obviously changed. And as you can imagine, as you're going through the process of palliative care or your dying process, many things are going to change. There will be moments when you're okay, and then there's moments when you're not okay. There'll be moments when your family are coping reasonably well considering, and all your loved ones, and then there'll be moments when they're not. And at different times, all of these moving parts need different support. So what unstable means for the people in palliative care is that we need to do something different. That might be the doctors or the nurses increasing a medication or changing a medication to meet symptom management needs. Or it might be that someone requires some additional counseling or something like that as well. And then once the person, once we make those adjustments, then hopefully the person goes back to stable again, where all their needs are being contained and met. And so people flip and flop between stable and unstable as they're dying, because that's exactly what we do in life. So if you just think about the last 12 months of your life, there were moments when you were feeling okay and other moments when you weren't feeling okay. Moments when you needed support, moments when you were coping yourself.
Start video.
Again, if we could just make sure that everyone's on mute, please, because there's a bit of background noise coming through. So then we have deteriorating, and what deteriorating means is that basically all the things that we take for granted, so the activities of daily living, your ability to mobilize on your own, your ability to dress yourself on your own, to bathe yourself, to feed yourself, all of these things that we take for granted in normal life, they begin to become impacted. And what that means is that then typically additional support is required. So someone might be in a hospital bed or an aged care facility, and initially they might just need one carer to assist them. But then as they continue deteriorating, they need 2 people to help them. Maybe they go from being able to walk to the toilet and use the toilet on their own to then needing a commode, maybe near their bed, or having people assist them into the commode or the bathroom. So it's the additional support, and basically it's the body and all of its functions deteriorating. Typically what we see in the deterioration phase is that people become increasingly fatigued, often due, or mostly due, to the deterioration process or the symptom burden of the disease process that's occurring. So deterioration, obviously things change, and all the medical people there and the psychosocial support and the allied health people, more input is being required to help that person be more comfortable. But there's also an acknowledgement that, their need requirements become more bed-centered. So you might have, so typically for us, here, I've got a glass here. At this phase in my life, let's say I wake up with this much energy of the water. That's the energy I have for my day. But people who are deteriorating, they might wake up with just this much. So what we do is that we rationalize the activities. So let's say having a shower every day might completely deplete that energy, and then the person ends up sleeping the rest of the day. But if we know that loved ones are visiting, we might say, hey, let's just do a bed wash today and not exhaust you, so that you've got energy for the things that give you quality of life. Because quality of life is the main goal. Comfort and quality of life is the main goal of palliative care. Palliative care in no way, shape or form is giving up on a person. And actually what I'll do after I explain these phases is I'll talk about probably the top 10 myths of palliative care, because these are the things that we work with loved ones and people accessing palliative care regularly about, because there's such a lack of education around this in society. And one of the most common things we hear from people is, how did I get to this phase in life and know nothing about this? And that's really common thing that we hear. People realize that the education system, that all of the systems are quite death phobic. So we're going through the deterioration phase, and then what happens is eventually the person will be sleeping a great deal. Like, let's say they might just even be awake for an hour or so a day at different moments. They might be sleeping through, and then you might be able to rouse them for something to eat or something like that. But what we do is that we don't burden them or the body with all of these additional demands, such as let's maintain showering every day. That might be important for you as a family member out of dignity, but for the person themselves, that might not be what's important to them. And that might change, which is why we always need to be checking in and never have assumptions about what those needs are. Then we go from the deteriorating phase to the terminal phase. And what the terminal phase is, that's what we consider the active dying phase. So the person becomes unconscious. And because of that, they're no longer eating or drinking, A, because it's not safe, but also because there is no need for that. The body's shutting down. So people often might say, look, why don't we give the person a lot of IV fluids? Because, you know, if any of us went to hospital and had IV fluids today, we would feel a little bit better for the next day or so, as those fluids are working their way out, because most of us are slightly dehydrated anyway. But the reality is that all of your organs are getting weaker and weaker, and they're slowing down and shutting down. So you end up just putting a burden on the heart to pump all of these things around, all of these fluids around, and additional things you're putting in the body, when already the heart is struggling, and it can make people feel very uncomfortable. This is one of the things that lots of people struggle with, because, and there's different cultures around the world where they don't like to present that they are, basically they need to feel that we're doing everything to keep the person alive. But in the Western paradigm of palliative care, what we're doing is seeking comfort and quality of life rather than prolonging life. Because what actually ends up happening is when we prolong life, and people are towards that end phase of life, normally what we end up doing is just prolonging the dying process, which is the most traumatic and uncomfortable aspect of it for many people. If I said to you, you know, you've got 6 months to live, but we could make it 7 months, but those final 2 months are going to be in bed, mostly unconscious, having people, you know, clean up after you and things like that. Most people consider things like their dignity, the burden on the loved ones and things like that, and they think, no, that's not actually quality of life for me. Now, everyone's different. So there are also people that present and say, look, for whatever reason, I want to stick around as long as I can. But the medical professionals, they also have a responsibility to not cause suffering. And sometimes that can be an important conversation to have. And this is where education really comes into it as well. So the terminal phase typically lasts it can actually happen very rapidly. For, you know, minutes or hours, but typically it would go for somewhere between 1 to 3 days. I think the longest I've seen it is about 16 days, but that was quite rare in the 26 years I've been involved in palliative care on and off. The terminal phase, basically the person's going through the dying process, and one of the most distressing things is the shifts that we see in their breathing and their presentation. So the first thing you notice is they begin becoming very gaunt because the subcutaneous fluid that's in our skin, all the fluids begin to leave the body and they're not being replenished. So you start to see things drawn in like the cheeks, so people can look quite differently. Another thing that occurs that upsets a lot of the loved ones, and we always say that the terminal phase is more distressing for the loved ones than what it is for the patients, because the patient's unconscious, much like when you're asleep. So, and what happens is in that terminal phase, that your breathing changes. And there are two things that occur. And the first one is secretion. So normally, and you'll probably hear me do it because I'm talking, I just had to swallow saliva then. So, normally when we feel a frog in the throat and we have some secretions there, we clear our throat. But if I'm unconscious, and the same thing would happen in your sleep, if you're fast asleep, you're relaxed, you're not noticing that the secretion's sitting there, and that will impact the noise of your breathing, which may be a snore or something related to that. So in the terminal phase, you can have a kind of gargly breathing, and this often upsets the loved ones because they're thinking, okay, my loved one, the person I'm supporting who's dying in this terminal phase, they're struggling with breath. But I've heard a palliative care doctor explain it as in, it's kind of like when you're drinking a soft drink through a straw and you've completely finished the drink, but there's that one drop there that you just for some reason can't get. And as you suck through the straw, it makes that rattling sound. So it's kind of more mechanistic than anything. Now, there are drugs that the medical professionals give to help dry up the secretions, and they can give those, subcutaneous. So that's a good point to mention, actually, in palliative care. So obviously, if I'm unconscious, I can't take all the medications that I was taking orally normally up to that point. So then at some point, the doctor then decides to give the drug subcutaneously. So we can take drugs orally, topically on our skin. We can take them intravenously into the vein, like you get in hospital. And then the other way is subcutaneous, which is just like a little butterfly that they put under the skin, and it just goes under the skin, not into the vein like you do. It's not as intrusive. And medications are provided quite rapidly in that way. If there are many medications to be provided to help the person maintain comfort, they use what's called a pump. So one of those types of pumps is called the Nicky pump. And what that does, it's like a mini computer. So it's like the size of a tissue box. And what it does is it's a little computer, and they put all of the medications that are required over the next 24 hours based on what medications that was required in the previous 24 hours to keep that person comfortable. They'll put that into one syringe and put this into the pump. And then over time, very precisely, this computer injects that in very measured doses, that combination of drugs subcutaneously into the person to maintain their comfort. If someone requires additional medication because their symptoms change, they might need more medication for secretions or more pain management, such as morphine, which is the gold standard drug, which I'll talk about in a little bit as well. What happens is it injects it precisely. So what it does is it removes a lot of human error, but it also removes one of the most distressing things for loved ones, and that is you're getting distressed because of symptoms that you're seeing. You're ringing the bell, and the nurse isn't coming immediately. So it removes those kinds of issues that can occur because the medications are still being administered in that way. Then what happens is within the last hour or so, it will start beeping to let the medical staff know that they need to start making up the next syringe for the next 24 hours. And if any additional ones have been provided in the previous 24 hours, they're naturally placed into that syringe in the next 24 hours, so that all of the needs hopefully are being met. So like I was saying, one of the most distressing things is the changes of breath, and one of those is secretions, but the other one is like a kind of sleep apnea where the breath is slowing down. So the breathing will slow down, and you may have these big pauses. So some of you may experience that with your own partners sleeping in bed. They might be snorers, they might have a bit of sleep apnea. And as you're aware, it disturbs you, but it does not disturb them because they're asleep. And that's the blessing of that terminal phase as well, because they're unconscious. They're not aware of it. And they're basically, the physical symptoms bother them less and less. So when I say that, I can guarantee that someone's sitting there thinking, how do you know if someone is in distress or in discomfort if they're unconscious? Great question. So one of the things that is really interesting is that you can very much tell if someone is either distressed or uncomfortable when they're unconscious, because what they do is the impact of that begins to show. So on their face, they might have a furrowed brow, they might be grinding their teeth, or turning their head like this, even though they're unconscious. They may be groaning, and they may be restless in bed as well. So there might be movement. So ideally, what someone who is comfortable looks like is a child fast asleep, completely serene. And when we see that, we know that that person is in a comfortable space. When I talk to families, what I often tell them in preparation of all of this is that you know your loved one's facial expressions because you've been exposed to them your whole life. If you're looking at your mum, your dad, or a sibling or a grandparent or whoever, and they are there unconscious in that terminal phase, and you're looking at their face and you're going, that's their distress face, and you're picking up on that because those micro kind of communications, you're honed in and attuned to those, whereas the medical staff might not be if they haven't been in that particular place for a long time for them to develop the awareness of that. So it's very, very important if you believe or if you're seeing that to let them know, and they will act on that. So the changes in the breath, that kind of sleep apnea, what happens is they might, another thing actually to notice if there is distress is rapid breathing, like a dog panting. If someone is breathing rapidly and shallow, that is an absolute sign of distress. So what we're hoping for is more slow, peaceful breaths, but what naturally happens is there may be an out breath, and then there may be a significant pause before the next in breath, and you may hear like a kind of like you see in sleep apnea, you might then hear a and then they breathe again. And for the poor people that are there in the room, the loved ones, they're holding on to this and they're thinking, oh, geez, is that it? And then it comes back and it kind of frightens them a bit. And this can go on for hours and unfortunately even days. So it's very important to be aware of this and to consider it natural. I guess one of the ways to think of it is your lungs and your heart, all of your organs, all of you have been beating and operating with a particular rhythm for an extended period. And it's almost like it's just slowly trying, or not trying, but it's just slowly, as the energy gets withdrawn or consciousness does, they begin just kind of slowly petering out like most things would in an organic matter. And then eventually the person won't take the next in breath. And then the nursing staff, they will come in and do their tests and to see that the person is actually deceased and to declare that. When they're doing that, they will quite likely ask loved ones to leave the room. And but you know, I've been present for these for many, many times, and it's done in a very dignified way. And what they often do is still talk to the person and say, I'm just going to pinch your toe. And what they're looking for is just to make sure that there's no particular reaction. They're checking the heart, they're checking the breathing and things like that. But there's a set of things that they do to do that. And then the final, so you're thinking that's it with palliative care, but the fifth phase in palliative care is bereavement. And this is really important because for anyone who is dying, the only thing that they worry about is their loved ones. I've never, in thousands and thousands of people I've supported, I've never seen anyone or heard anyone say that they're caring more about themselves than their loved ones. Now, if you think about all of the way in your life, all of the energy you put towards making sure that the people that you care for and love are okay. And then what happens is when you're on your deathbed, you're looking out at these people. And as you're becoming weaker and you're becoming more impacted by what's happening, you don't have the same degree of energy to converse and make sure they're okay. And then what happens is that can actually be quite distressing to see that what I'm going through and experiencing is impacting my loved ones in this very significant way. And again, a very common thing I hear is people talking about the guilt that they feel. I'm causing a great deal of distress towards my children, my loved ones, based on what I'm doing. But yeah, it's an important thing, and that we do in palliative care is to let the patients know, or to try and get into that relationship dynamic as much as possible, to let the patients give us a heads up about who are the vulnerable people, who are the people that they're seeing suffering, and to then reassure them that we will continue that care for them during their dying process and afterwards as well. It's very, very important that we give that message to people who are dying and that we follow through on that as well. So that's bereavement. So they're the 5 phases of palliative care. Can't believe I've gone 24 minutes already just talking about that. I'm so sorry. We'll get to questions shortly. Some things to talk about in regards to the typical myths about palliative care. So the first one that is good to address is that palliative care speeds up death, it hastens death. It doesn't do that, and people get really confused. Like, what you'll often hear is, well, I don't want palliative care because my friend's kind of grandparent had that, and they told me that as soon as they gave morphine, or when that pump came out, that they died not long after. You know, that was them terminating their life. That is not what palliative care is. So we do have voluntary assisted dying now in this country and in other places around the world, and that's a very different situation. What we do in palliative care is it's all about allowing the natural process to occur, but we do our best so the person isn't burdened by the symptoms. So normally what happens is you will see these interventions, but it's just more about the kind of the timing of it. Now, this brings us on to the next myth, which is, and actually another thing is, you know, palliative care isn't about giving up at all. I've known people that have been palliative for 7, 8, 9 years. It's just that the disease process is slow, but they're palliative because they're not going to recover from the disease. And as the disease progresses, it will cause end of life. And interesting, so a typical one of this might be people with dementia. People can live with dementia for many, many years. But once you have that diagnosis, the odds are that you are going to pass away from something to do with that disease or the disease itself. So typically a very common thing might be a pneumonia, because when if the swallow begins to go, the saliva goes down, well, it's full of bacteria, it goes down into the lungs. And because of the disease process of dementia, their immune system gets weaker and weaker. And they spend a long time, they might spend a lot of time lying down in bed because of mobility issues or whatever. And so they're not kind of moving all the fluids and stuff around. And so, yeah, you can have that occur where they will die from dementia, rather than, well, they're dying from pneumonia related to the dementia based on the symptoms of the dementia. Palliative care as well, like I was saying before, sometimes what happens is the doctor has to make a call for nil by mouth, because depending on the disease, and again, dementia is a classic one, where the swallow might go, and another one is like motor neurone disease, where it might not be safe to swallow. And then sure, you might be propositioned with, well, do you want a tube in your stomach to be fed for the food to go through that way? But that can create other complications, such as the person will continue deteriorating from the disease in other ways. But also people, when we put those, tube feeding, and they're having that, they can regurgitate that, and then that can go into the lungs as well. So it's not always the best solution. And again, it can be the situation where what you're doing is prolonging the dying process rather than prolonging quality of life. So when the doctor declares, nil by mouth, then obviously we can only sustain ourselves so long without food, but especially without fluids. Palliative care isn't just provided in hospital, it can be provided in hospices. And of course, we're so lucky in this country, it can be provided in home with different home support services that are available. Something to think about, though, is the impact on the people, the loved ones that are providing that care. So, if you don't have the grand wealth to have a 24-hour nurse there, which would be incredibly expensive throughout that process, then you're relying on your loved ones, toileting you, changing you, providing all of that care. They do 99% of the care with basic no training. And then when they see symptoms, they jump on the phone, and then the service, whatever service you're using, the nurses will come around and they'll contact the doctors, and that's how they manage the medications and symptom management. So there can be delays there, but just the distress and the responsibility. I know that in the hospices that I've worked in, it was pretty common to have people that were attempting to have palliative care at home, but they ended up having it in a hospice. Now, I would definitely recommend, having worked in hospitals and hospices, that if you do end up going into a hospital setting or into a facility, that basically the two best places that do palliative care are palliative care units, and the other one are aged care facilities, because they're doing it all the time. Now, our aged care system is absolutely under massive strain, and the lack of staff and things like that, it's causing a lot of problems. So, but, typically if you're in a good situation and the staff and you're trusting it, and you've been there, your loved one's been there for a while, it may be best to keep them there rather than to move them. But if you're in a situation where you're trying to decide, should we go home, should we go to a hospital or go to a hospice, primarily I would really recommend going to a hospice, because every single person there is trained in that specialized field. I know that there are different places that I've seen, and I've worked with many nurses and doctors that are not experienced in palliative care. So don't assume for a second that your healthcare provider is specialized or trained in that. It's very important that you look into that and make sure that they are. Other kind of myths is obviously, well, here's a good one. We need to protect children from being exposed to death and dying. So this is actually how my journey started. I didn't have any pets growing up, so I didn't experience any of that. And the first death I experienced was my best friend when I was 18. I was absolutely devastated, and very sadly, I remember saying to my mum, "This is your fault," because I wasn't exposed to death, which was a really harsh thing to say to my poor mum. But you know, I like so many people I've come across was just floored that how do I not know this? How do I not know the depth of this grief and nothing about this death and dying mystery? So, you know, I always recommend that we include children in this process. You don't have to burden them with all of the detail of it. You know, it has to be appropriate to their phase and stage of development. But it's very important that we expose them to this. And one of the best ways to do that is through having pets. But, you know, also, you know, again, I remember in my childhood, an uncle passing away and me being told to sit in the car as my parents visited him in hospital, and sitting in the car for an hour or so and just wondering what that was all about, as opposed to being exposed to it. You know, most of us will be exposed to it and be in the position where we have to step up. And the more educated we are about it, and the sooner that we're educated about it, the better. Now, pain, and another myth is that dying is painful, and it's absolutely not a guarantee. It depends on what's happening with the disease. And it also depends on things like, you know, I know if I lie in bed, if I have a good night's sleep, let's say I get 8 hours sleep, and then I decide, let's say I've got the flu or something, and I lie in bed for another extra 3-4 hours, I know my shoulders are going to hurt. I know my hips are going to ache. So if we spend a lot of time in bed, what we end up doing is feeling aches and pains that requires maybe some, you know, some Panadol or something like that, or maybe something a little stronger to help with that and to relax that as well. But, you know, pain, one of the things that happened with the voluntary assisted dying debate in Australia is that fear was used as one of the tactics. Now, I'm all pro-choice everything, so I'm okay. I'm not saying that I don't agree with voluntary assisted dying, but I think that one of the things that we do in society these days all around the world, whether it's politics or religion or whatever, is that we use fear as a way of trying to convince people towards our side of the argument. And one of the sad things that I witnessed over the years was the voluntary assisted dying using the people's fear of pain as a way to kind of diss palliative care a little bit. Pain is managed really well, and it's managed with morphine. Typically, it's the gold standard drug. I've seen people who've had too much morphine, and it is not pretty. You know, they're hallucinating, they're very uncomfortable. They'll be trying to grab stars or things that they're seeing out of the air. No one in the medical field wants the extra burden or distress of watching someone who's been over-medicated with that. Another thing is, because it's a Schedule 8 drug, it requires 2 nurses to provide it, to check the dose, to make sure that that's what's being prescribed by the doctor is correct. And if they view it as not correct, they will question that as well. So there are a lot of safety mechanisms to make sure that that doesn't occur. So again, though, if you're in a hospice setting, or a palliative care unit, things like that are handled very, very well, and you'd be in a better position in regards to that. In another aspect of that is, a lot of people get anxiety about, well, I don't want to become an addict. I don't want to be addicted to morphine. Now, if your body is requiring this medication, then your body is consuming that medication. I'm in no pain. I have no need to take morphine. If I took morphine right now, I would be stoned off it. So it's a very, very different experience when you need it versus someone that takes it, say, black market wise for whatever effect. So typically they tend to mix up the drugs a lot as well, because what happens if you stay on one drug for too long, it can actually have the opposite effect as well. Now, I'm not a medical professional, so I'm not going to dive into that, but just to explain that things that work, sometimes when they stop working, the medical staff might begin changing around the medications that they're using. So look, they're the kind of myths around palliative care. And what I'd like to do now, because we've got about 25 minutes left, I'd really like to open up the conversation to any questions that anyone has. And a really interesting thing, an area that I'd really like to discuss, because this doesn't happen often. I know that, every now and then I do talks on these things, and the space or the conversation tends to be dominated by the palliative care specialist promoting palliative care and educating about palliative care. But there is a far equal and important aspect to this, and that is, how does one die? I get asked this question a lot. How do I die? I've been promoting life my whole life. I've been trying to live well and all of this. How do I let go? How do I begin that process with dying? And this is a significant anxiety that people have. And also the existential distress that can be caused as well for many people, whether that's watching your loved one passing away, whether, all of a sudden you become heightened to the awareness that we have, we are constantly facing uncertainty, and we never know what's around the corner. And the person I love most in this world may die today or tomorrow, or I might be faced with that. So it can create, it's a big disruptor to the normal status quo. And in psychology, Irvin Yalom, who's one of the psychologists or psychiatrists or both, that studies or that researches a lot about palliative care. He refers to it, one of his books is titled Staring at the Sun. It's something you can kind of do in small glimpses, but if you spend your life, like myself, looking at it all the time, it can be quite discombobulating and destabilizing, but equally, it can be very freeing when we accept the reality of death and dying, when we accept the common humanity that every single one of us here listening or watching this right now, myself included, will face this. We are going to face this. Now, if I said all of us are going on a holiday, or all of us are going to get married, or all of us are going to study a degree, we'd begin putting some preparation into that. And the preparation for coming to terms with death and dying of ourselves and our loved ones depends on how we choose to live. And I'll talk a little bit about that as well. But first, I'd like to open up some questions and conversation with you good people, if I may. Is there anyone that would like to unmute themselves and ask a question?
Yeah, hi. I'd like to ask a question, please. Do you recommend meditation for people who are undergoing, the latter stages of life?
Yes, absolutely. Fantastic question. Meditation, I would consider, is essential. I'm a lifelong meditator myself, and what's really important is to realize what most people do to deal with their discomfort in life is they will do two things. They will distract themselves, typically with work, hobbies, managing other people's life, like we kind of do as parents. And the other one is we tend to numb out. We might comfort eat. We might sedate through overeating. We might sedate through drinking alcohol or having other substances. They tend to be the two main ways that we kind of deal with distress or discomfort in a kind of dysfunctional way. one of the things that is very important to realize is that as you are dying, you're not going to be able, in that in the later phase of the deteriorating phase and during the terminal phase, you can't just get up and walk out and stretch your legs or go for a jog if that's what you've done your whole life. I know people that's a great mental health strategy. They come home from a hard day's work, go for a 5K run, they feel wonderful, and they might do that in the morning. But all of these physical things that we're doing, they're not at our disposal. So think about what I can do in bed. Now, I'm a yoga teacher and a meditation teacher as well. And what's really wonderful is more and more, because more people have experienced yoga and meditation. 26 years ago when I started, you rarely ran into people that did. And now at least people have experienced that kind of peace and serenity, like at the end of a yoga class when you lie in Shavasana, or they've attended a meditation class, or they've read books and had CDs or learnt from someone. Meditation is a way of, especially mindfulness meditation. What it does is that it helps remove the distressing narrative that we overlay on top of the experiences that we're having, and instead just deal with the reality of what we have. On a more simple level, what it does is that it soothes your nervous system. So obviously that's going to be a wonderful thing. But also what it does is it allows us to go inwards. And this is a very natural inclination to do when we're dying. What we do is that we all of our energy, our awareness and things, it tends to become more inward rather than projected outward like we are in life. So the types of meditation I would recommend, anything around mindfulness. In preparation for letting go, which is also really important, there's a I guess a spiritual, a philosophical approach and that's called Advaita Vedanta or Vedanta. And a lot of this is not so much on belief systems and rituals and practices, but about the reality of, we are awareness. And there's particular meditation techniques in Advaita Vedanta where it's focusing on that. And that can be a very, very helpful thing as well to experience and to trial as well, and to play around with. You don't have to, you can grab these techniques out of books or whatever. I encourage people to experiment with meditation. You don't have to swallow the whole pill with it. You don't have to join a cult. You don't have to join a religious movement. You don't have to sell your soul or anything like that. There are plenty of these techniques that have been validated through research, and especially, like the work of John Kabat-Zinn with mindfulness from the University of Massachusetts, amazing work that has kind of removed a lot of the dogma from these practices, even though they did originate in particular spiritual belief systems and religions. But, these spiritual belief systems and religions, they were the psychology of the day. They kept civilizations bubbling over for thousands and thousands of years. It's just that in the last 100 or so years, we call it psychology, and we're being taken from these. If you actually teach, I teach counseling in a master's course at a university. And so many of these techniques you find in all of these ancient approaches, and they've been taken throughout history as well. So that was a really long-winded answer, Frank. But yes, absolutely, I would recommend meditation, and also how to fall asleep. Like, what do you do when you wake up in the middle of the night? Because that will happen in your hospital bed, and that will drive you nuts. And if you're in the habit of, when you wake up in the middle of the night and then you start turning on yourself, I can't believe I'm awake again, and then everything that goes on in your life is whizzing around in your brain, and if you do that repeatedly throughout your life, of course, that's what's going to happen when you wake up in the middle of the night and you're in hospital during that time that you're going through those final stages of life. So having ways where we're more of a self-contained unit, not being able to rely on external things. We still will have those things at our disposal. There's medications that are provided that help ease the distress, and they work incredibly well. But besides that, I like to know for myself that when I enter into that, that I also have a lifetime of practice of meditation, being able to calm myself. And another really, if I may tack on to that, is your self-talk, your self-compassion. This is absolutely essential. If there was one thing, and people said to me, tell me one thing that will give me better quality life, just one thing, I'm only going to do one thing, I'm not going to do anything else you've suggested, just one thing, it would be work on your self-compassion. Because what you naturally do when you realize that you are dying, or when you've been handed that diagnosis, is that you reflect on your life. You think about your legacy. And if you are very harsh and critical of yourself, then as this natural tendency is occurring, you're going to beat yourself up. And you've reached the end of the life, and it's too late to do anything about this relationship or that relationship or whatever, or these mistakes that I made. And that can be torturous for you. So developing self-compassion, and I would encourage all of you to look at the work. One of the researchers, the leading researcher in this field, is a wonderful researcher called Christian Neff, N-E-F-F. She has a website, she's got lots of wonderful books, but she's also got a whole website of different meditation and techniques that are for free that you can listen to and begin developing a much softer, caring, self-loving, and rather than a self-loathing voice. Many of us were raised and controlled by our parents and our educators, our teachers, and our bosses by using shame. It's the easiest way to control someone, is to trigger their shame button. And often many of us talk in the same way to ourselves. And shame is demotivating. Shame is judging your totality of who you are. The totality of who you are is far too complex to judge based on singular acts. So, and the beautiful thing, one of the most beautiful elements of self-compassion is the shared humanity, the common humanity. We are all in this together. We're all figuring it out as we go. None of us are experts. And, here I am talking to you about, ideal kind of death and stuff like that. I have no idea how I'm going to go. I'm sure I will shit myself as well when I get delivered that news that, guess what, Satyam, you've got this disease and you're not going to recover from it. And it is palliative. I'm not going to take that lightly. And I'm not suggesting for a second that I would. But what's important is I have a big toolkit of things at my disposal that I can use. And if this one doesn't work in this moment, I'll try this one. And if this one doesn't work, I'll try this one. And that's what we want to do, as well as being familiar with, rather than just whenever the fear of dying comes up, I push it to the back of my mind and distract myself and don't go there. Instead, because of the decades of going there, most importantly, the decades of talking to people who are dying and asking them what it is like, and them telling me, that has set me at ease, because it is not as bad as you imagine. And this is really interesting. This often happens in life. You might have great anxiety about different things. You might have had anxiety about listening to this and it being triggering, and you're going, it's actually not that bad. That's normally what happens in life. We exaggerate the negative impact of future events on ourselves. It's a common psychological trait that human beings have. So instead of that, though, my exposure to it. So if I can quickly tell a story, when my friend died, I went and volunteered at a place that no longer exists in Perth. It was called the Cottage Hospice. And I did lots of training over many weekends, and I finally turn up, and the lady, the head kind of volunteer lady that was there on the day, she said to me, "You're a man, what do you know about arranging flowers?" And I was like, "Oh, that's not what I volunteered into palliative care for. I don't want to arrange flowers." And she said, "Oh, look, you're no use to me. Just offer people coffee, tea, Milo, and sit with them and listen." And I thought, sweet, that's all I wanted. I thought, you know, this was going back to the early to mid 90s. I thought in that my young 20s, if I could position myself right at the doorway of death, I would learn something about this mystery that would take away this anxiety and fear and grief that I was experiencing. But the reality was, or what I did was I sat down and I would ask people, I would do positive inquiry. And I'll never forget the first gentleman I spoke with, who was passing away from cancer. So at the cottage hospice, the majority of people were dying from HIV, AIDS, and a form of or a form of cancer. And this gentleman was passing away from cancer, a particular cancer. And I said to him, you know, what do you think about as you lay there? And I was asking, just really inquiring about what it was like. And I never changed that approach. And this particular gentleman, his wife had died just a few weeks before, also from a cancer. And he was grieving so hard. He just kept saying, "I miss my best friend. I miss my best friend," and really kind of crying. And, you know, in that moment, I realized that the act of dying is an act of living. He's experiencing grief just like I was experiencing grief from my friend dying, from my best friend dying, which was, you know, just a powerful moment. But you know, it was, you're still faced with all of the difficulties of life as you are dying. But the interesting thing is, so a way to put it is, you know, when you've had a huge day or a huge week and you're so fatigued, and when you go to bed that night, regardless of all your to-do list that is not completed, regardless of the issues that you have to face tomorrow, all you're thinking of is, as soon as my head hits that pillow, I just want sleep. I'm out of here. I'm, you know, whatever, life, whatever, today, I'm just out of here and I just want to fall asleep. This is the saving grace of the dying process, is that your energy and your level of fatigue, all that the people want to do, and the most common thing I hear towards end of life is, "I just want to close my eyes and fall asleep." And that is a real surrendering. And, you know, you've done this every single night of your life, except when you're younger and you skipped nights of sleep. But typically you've gone through the dying process every night of your life. It's the act initially of falling asleep, of becoming unconscious. And then in that unconscious state, you go through that terminal phase where you're not conscious of it. Now, let me add on something else as I go, if I may. There's lots of research about this, and I've witnessed this many times, or I've heard many people talk about this, many people. There are two things that really support us as we go through the dying process. I haven't heard everyone talk about it because people have different levels of awareness. But the first one is, something really common is that as people are going through the dying process, they will often have dreams about dying. Now, if you're going through something huge in life, it will often play out in dreams or things like that. It's one of the ways that we think that human beings kind of cope. It's kind of a coping strategy or a management strategy for our psyche, is to play stuff out in dreams. So what often happens, what lots of people talk about, and is the experience of dying, of leaving their body. And quite often they will come, you know, they'll talk to me the next day or whatever, and they'll say, "I had the most sublime dream where I was dying." And I would inquire about, what was that like? What did that feel like? And they would say, "It felt absolutely peaceful. It was so beautiful. It was amazing." And it just instantly sets them at ease. Mm. Another experience thing that can happen is that many people Now, I don't have a belief system any particular way, just to throw the disclaimer in there, but many people have loved ones visit them who have passed away before. It's never people that have done them harm or that they have a negative relationship. It's always supportive, loving people that have been present in their life. Well, when I talk about, and there's lots of research about this as well, the time I often think about this is I was in a room with a lady who was dying. She had about a week or so to live left, and her daughter was there as well. And I was talking to the both of them, and the mother was holding up, the mother who was palliative was holding up a lolly, and the daughter said, "Mum, what are you doing?" And she said, "I'm trying to give it to your father, but he can't take it." And the daughter was kind of, dismissive of that. And I, because I'd heard of this and witnessed these types of things over so many years, I normalized it. And I said, "Oh, does he visit often?" She said, "Yeah, he often sits out in that chair in the hallway and he yells out every now and then, 'Are you ready to come home yet?' Just like you would in life." So these things happen very, very commonly. Now, whether that's something our brain does, or whether it's something built in our psyche, a protective mechanism, or whether reality is something completely else, and there is this whole other afterlife dimension, whatever, I don't know. And whatever your belief systems are that sustain you and how you are in life, so be it. But the important thing is, I think it's important to talk about this, because it is such a common reality for so many people. And it's something that absolutely soothes people as well. Another interesting thing is, and research-wise, in regards to the kind of psyche coping mechanism, is that there's an incredible growing field of research on psychedelics and managing death anxiety. And in particular, the drug psilocybin or psilocybin, which most of you might be familiar with in regards to magic mushrooms. So there's lots and lots of research about this. And what that does is that it gives people a visceral and real experience of expanded consciousness, where they feel connected to everything, where they feel safe and supported in the universe. So going back to Frank's question about meditation, over years of meditation, I can enter into a state like that in deep meditation, where I feel connected to everything around me and I feel supported, and that it feels like a loving environment that is the cosmos that we exist in. And that is also very soothing as well. But people can also access this through belief systems of their particular religions or spirituality as well. But it's really nice to have a lived experience of this too. And not all people experience their religions or spiritual belief systems in that way. So having a meditation practice or a prayer practice or whatever that is for you, where you feel the kind of the embodiment of the connection and the expansion of your consciousness, can be a really good thing to do as well, to give yourself that reassurance and to be able to practice that as well. I'm giving very long-winded answers to these questions. I'm just having a quick look at the chat to see if anything's popped up here. Yeah, so it's very common that I hear people say, "I wish I knew all of this." And again, it shows how much society is letting us down. But there's death cafes and more. Only recently I did a talk at the Disrupt Festival with an absolutely wonderful group of people from different walks of life, from the Center of Stories. These things are happening more and more, and it's great that you're all exposing yourself to these. Are there any more questions? I'm happy to go for a little bit longer if people have any more questions.
Can I ask a question, Satyam?
Please.
You've mentioned Advaita, and the same would apply to most Eastern philosophies and Buddhism in particular, and they have a very different view an approach to dying than we do typically in the West, especially, you know, I think people who've had a very, you know, been exposed to particularly Western religion, they have a completely different view of this, and it can be a terrifying prospect, because the question arises, well, what will happen to me when I die? Will I burn in hell? That's what I've been told all my life, right?
Mm.
And so what's been your experience in terms of mitigating these sorts of fears that come up for different people about, oh, what's going to happen to me, you know? Does
Yeah.
that ever
So,
come up
yeah.
at all?
Yeah, great question, Bernie. Thank you so much. Look, sometimes our belief systems can kind of put us in a bit of a trap. So I was raised Catholic, which of course has that belief system of heaven and hell. And again, this is where the self-compassion comes into it, because the way that I relate to myself, the way I talk to myself, is also how I imagine people, including your concept of cosmos, God, whatever that is, perceives you as well. You know, I think, you know, when people have those types of belief systems, it can be quite tricky to manage that. And sometimes the best approach, if it's a loved one who is really turning on themselves, and they might say, for example, they are Catholic and they believe they're going to go to hell for something because maybe they lived in sin, say, for example. And then what happens is the best course of action is to have an authority in that particular belief system to help alleviate their fears, rather than someone that doesn't. So that's a very simple, first off, a strategy for that. I think as well, though, you know, being able to correct these in life as we go, rather than trying to squish these adjustments in our belief system and how we relate to our particular religious or spiritual belief systems right at the end, because right at the end of your life, there is a lot of pressure. You're watching your loved ones suffer because of what you're going through. You've got your potential physical suffering, even if it's just the discomfort of being stuck in a hospital bed as you're going, or whatever the situation is, or the loss of dignity because now you have to soil a pad rather than go to the toilet, and anything like that. So, you know, being able to deconstruct or create a more broadening perspective of these religious belief systems that incorporates a more loving concept of afterlife, I think, is really important as well. Another interesting thing to do, so just to kind of tack on to that as well, is in regards to our self-concept. So this is something really difficult to let go of. So your psyche, your ego, is constantly promoting yourself. It's constantly protecting yourself. And this can be, and then all of a sudden, when you're given the diagnosis of death, or you're approaching the end of your life, all of a sudden, it's kind of, you have to kick that into neutral, or possibly even reverse, where it's about letting go and allowing, when you haven't been doing that your whole life, especially if you're someone that might be someone that operates, because of whatever reason, with anxiety or fear about life and what happens in it. Then one of the things that we can do is we can become quite controlling. Now, if I become protective of myself, I naturally extend that out to my loved ones as well. So again, how I treat myself is normally how we treat others as well. And if I, let's say, an example might be, let's say I absolutely love my job, and this particular role that I am, it resonates and it reflects who I am and what I do. And then all of a sudden I lose my job for whatever reason. And then it feels like I've lost a part of myself. Well, you might have that feeling with a loved one. you know, whether it's through a separation of death or a separation through divorce or something like that, or just a change in location or whatever, you know, you can feel like you're losing a part of yourself. So what's really important, again, coming back to that meditation or a technique such as, and it's an interesting thing to do at the end of your day, is like taking off your roles. So imagine, like, if you think about all the roles that you play in life, as a partner, maybe, as an employee or an employer, friend, sibling, parent, all of these roles that you play that really kind of make up your concept of who you are, to contemplate each one at a time, and then just imagine like you're taking that role off like a heavy coat and just letting it fall by your feet. And this is a nice technique of stripping away these roles that we play in the life, these kind of more ego-based roles, so that till we get to the point of we're just being. And again, in a lot of the Advaita Vedanta meditations, to use an example, I'm just using it as an example, this, again, like Bernie said, you know, the Buddhist philosophy as well, obviously works a lot and contemplates a lot. And then you've got the other philosophical mysteries as well. But you know, being able to break it down or just come back to awareness, just the experience of your awareness. And again, you can enter this into states of meditation. A nice thing, and to add on, sorry, to go back, something that I wanted to say in regards to Bernie's question about managing that. And one of, and I remember hearing Irvin Yalom pose this question to one of his clients, and I thought it was brilliant. And that is, before you were born, before you existed, did that bother you? And the answer is no. So when we think about death, we can only see it or when we think about afterlife, or death as in death has occurred and what happens to me then. The only context we have is myself in a body, an emotional being, and with you know, mental awareness, with a nervous system, with all the suffering that our nervous systems cause us. None of that is with me. You know, what we do know is you don't have a body once you've died. Your consciousness is separated from your body. That much we know. That much is assured. So that means if you've lived a life full of pain, emotional, psychological, spiritual, whatever form of pain, physical, that you can't have that because you don't have a body to have that. Your self-talk, your judgment, all of these things, you have to think about it not in the context of having a body and a nervous system, because that's how you experience your suffering. The reality is that death is an alleviation of suffering, the suffering of life, because it takes away life itself. And there is a lot of suffering in life, as you all know. Not just that, there's a lot of amazing experiences, and amazing experiences come from suffering as well. It's very beneficial as well. So just mindful of time, is there any final questions or statements? No, that's it. I could talk about this stuff till the cows come home. Like I said, I'm also a counselor, accredited mental health social worker. I work a lot of people on these issues, many people as well who actually aren't palliative, but just want to get a head start on working on these issues as well. There are many people like me out there, and I think people that specialize in palliative care, you know, seek them out. Like I said before, do not assume that all healthcare professionals or that all allied health people have that degree of awareness and comfortableness and knowledge and are as specialized as the people that are. I think that's really important to understand. Much like in life, reach out, be curious, experiment. Very, very important. If you feel that I'm not going to be able to cope with, you know, I don't have, if you're sitting there going, I don't have any of these skills he's talking about, what am I going to do? It's not too late. Start working on it. What a beautiful realization to have, and not too late. I've met plenty of people that have that realization on their deathbed. I encourage you not to be that. I encourage you to step in, lean into your fear about death and dying, because I absolutely promise you that it is not as scary as what you imagine it to be. And that people that embrace and work on the comfortableness and acceptance of the end of their life and the life of those that they care about, you live a much richer life. You live a life typically full of gratitude and appreciation, because you know there is an end point. You don't keep kind of just pushing away those relationships that you know you need to work on, but you can't really be bothered sorting that out at the moment. You realize that I might miss my chance. And I certainly meet many, many people who do and have that regret. If I can finish with one last thing, a little kind of thing, you know, earlier this year, I was challenged to think of a phrase about how someone could have a good death, like if you could put it into one phrase. The phrase that I came up with was, based on my experience, is to find a way to be significant in a meaningful universe. And what I mean by that, a meaningful universe, I'm not talking about religion or spirituality. I'm talking about the place that you live, whatever universe that you exist in, the universe of your family, your culture, all of it, your belief systems, and to be significant within that, because it is our legacy that is one of the ways that we live on. We just don't know how much impact the things that we do and the interactions that we have, how they continue to carry through generations of people. You might be particularly kind to someone, and that may impact the way they parent, or you may support someone in a particular way, and then that might impact how they relate to people at work or whatever. This is what it's all about, that shared common humanity, being able to support each other, to be brave with each other, because ideally what we're doing is walking each other home, and walking each other through life and home at the same time. And to be able to have the ability to understand your legacy, so that when you're on, and to have that self-compassion, so that when you are literally on your deathbed, contemplating your life, it's through eyes that are full of unconditional love and acceptance for self and all of you around, all of those around you. And then obviously it will be a far less complex experience, as opposed to having all of these things that aren't quite in an ideal state. And they're not always in an ideal state. And sometimes nothing's in an ideal state. But at least what we're doing is our understanding of that. I'm not making it worse by judging the totality of who I am, or beating myself up, or believing I'm going straight to hell because of this, this, and this. So really engaging with life and stepping in, that would be my advice. Thank you so much. I love talking about this stuff. Reach out if you ever want to have a chat. I really, really appreciate the people that have turned up. It warms my heart, and I'm so happy that, you know, maybe this is the beginning or a continuation of a wonderful journey for a wonderful life and a wonderful dying experience for you and your loved ones. Thank you so much. Take care, and I'll see you around.